Welcome to another edition of the Stanford Health Policy Forum. My name is Keith Humphreys. I'm a professor of psychiatry here at the medical school, and I'm very happy to see you here for our first event of this academic year. You can find out about future fora, as well as watch tapes of prior events on our website. That's Health Policy Forum, all one word, healthpolicyforum.stanford.edu. Now today we have a special event in the middle of our forum, which is Stanford's Emergency Alert Service. Will go off at 12:05. And I hope you appreciate the work I had to do to get that to happen during the event. The strings were pulled, it was a lot of work. So what that means is anyone who is a Stanford faculty, staff member, or student will get a message or a phone call, whatever you're scheduled for, at 12:05. So if you could turn your phones to silent and answer, respond discreetly that you've gotten the message. And if it's very disruptive, we can take a break, but we'd rather not to, so we'll just try to do it that way. Thanks for your forbearance on that. So we can't do events like this without academic leadership, and we've had outstanding academic leadership and support from the dean's office. We have a new dean at Stanford, Dean Lloyd Minor. Like all faculty, I came and I met him, and I said, you know, it is wonderful to have you here. Welcome to Stanford. And can I have some money? And so I want to thank him for his support of the forum, and he's going to welcome you here today. So Dean Minor.
Well, thank you, Keith, and thank you for the great work you've done in organizing this symposium and working with Ryan Adesnik and others on this very important health policy forum series that we offer here at Stanford Medicine. This topic is particularly important, the topic of serious mental illness, and as you'll hear from the very distinguished panel that will begin in just a moment, the manifestations of serious mental illness, such as the manifestations and consequences of serious mental illness, such as inappropriate incarceration and violence. And I can think of no other topic of greater significance to our society than mental illness more broadly, and certainly its most serious manifestations. Families are torn apart by mental illness, and particularly by serious mental illness. The people affected by mental illness are affected in ways that alters their lives in ways that few other diseases or disorders do. And having this distinguished panel lead us in a discussion of where we are today and where we could hope to be in the future, what we need to know and what we're doing to learn what we need to know is a very important role for us here today and moving forward. It's something that we try to do every day at Stanford Medicine. We want to lead the biomedical revolution, and we want to do that by leveraging and empowering our innovation in all aspects of our mission: research, patient care, and teaching. I think particularly in the area of mental illness, with Dr. Roberts' leadership, we have an outstanding department of psychiatry and behavioral sciences here at Stanford. And we're doing transformative research that related to mental illness that just this Monday led to a Nobel Prize to Tom Sudoff. Tom is a neuroscientist who looks at vesicle transport and at the mechanisms controlling the release of neurotransmitter from vesicles. And disorders of transmitter release, disorders of transmitter formation, we know play an important role in many mental illnesses. And another member of Dr. Roberts' department, Dr. Carl Dijsselhoff, is doing incredibly innovative work at the interface of behavioral sciences and very basic molecular, genetic, and cellular neuroscience. Carl's a psychiatrist, and when Carl talks about his interest in psychiatry and in basic neuroscience, he talks about being impressed as a medical student at the consequences on people that are extracted by mental illness. So I thank you all for being here today. I want to thank the panel and Paul Costello for moderating the panel. And let's learn a lot and let's plan a lot for what we can do to have further impact in this very important problem of serious mental illness. Thank you. Keith?
Thank you so much, Lloyd. So why are we having this panel today? Because October 10th is World Mental Health Day. There will be events in more than 100 countries today designed to increase understanding of mental illness, to lower stigma, and to advocate for better care. Our niche is health policy, so we wanted to focus on that aspect of mental illness, and it's complicated to do that because there's a public health policy involvement in this issue, there's a clinical medicine policy involvement, and there's criminal justice involvement. So we felt we needed a diverse panel who are tops in all those areas, and I'm happy to say we've got them. So starting on your right, however many responsibilities you have, here's a chance to meet someone who has more. Sheriff Lee Baca heads a sheriff's department with over 18,000 employees, responsible for law enforcement in more than 50 cities and over 100 unincorporated areas as well. He also has spoken very eloquently about what it is like to be the head of the nation's largest psychiatric facility, meaning the LA County Jail. And it's because of the thoughtful remarks we've seen from him about why mentally ill people are in jail, what happens to them there, and what alternatives there are, that we very much are happy that he's come to Stanford. And then immediately to the sheriff's right is Dr. Laura Roberts. She is the chairman of the Department of Psychiatry here at Stanford. She is a nationally recognized physician, an expert on the treatment of mental illness, as well as an expert on ethics and social policy, and we're delighted to have her here as well. Thank you. And then to Dr. Roberts' right is Dr. Harold Pollack of the University of Chicago. Harold is an expert on public health policy, on social welfare and intellectual disability. He also writes regularly for Washington Post newspaper, and he's had some very strong pieces I commend to you about these issues. And then finally, our interview today, as usual, will be Paul Costello, who's the head of media and communications at the medical school. Paul could, I think, interview anyone about anything, but he actually has, in addition to that, a unique substantive connection to this issue. He used to be the press spokesperson for First Lady Rosalind Carter when he was in the White House, and she is, in my lifetime, one of the great advocates for the mentally ill. So we've got an outstanding panel, and they will talk together up to about 12:30 or so, and then we will open it up to your comments and reactions. So thanks for coming, everybody, and take it away, please, Paul.
Thank you, Keith, and thank you, Dean Miner, and welcome, panel. I want to start with tragedies. Last month, Aaron Alexis walked into the Washington Navy Yard, as we all know, and allegedly killed 12 people. And in the days that followed, we learned a lot about Mr. Alexis and his mental instability. And so on the one hand, this mass shooting was seen by many as an indictment of a fractured mental health care system. And on the other, it portrays mentally ill as violent. And we know that the mentally ill are more often not the perpetrators, but those who are acted upon aggressively by others. So I want to begin by asking you if each of you think that mass shootings like this are largely preventable tragedies. Lee Baca, why don't we start with you? What can be done to stop these?
Well, let's just start with the whole of what the human mind is all about and get into how fragile it truly is and what we do as human beings to not take as good care of it as we should, which then compounds what that mind functionality is, and then get to the place where how does this all happen in the first place? Because we have in the room here some pretty bright people, but the traveling from birth right up to adulthood is loaded with a variety of things that cause people to somewhat disintegrate in terms of clarity with where they're going, why they're here, what's their purpose, and the whole thing about mental illness is that it doesn't come quickly. It comes in various forms and stages of time, and so when you talk about this subject, you have to realize that human beings aren't necessarily their best caretakers, even when they're adults. And so then the key then is how does this all tie into the medical field, which I'm glad Doctor is here because he can help us with to what degree is the antidote capable of handling the extensiveness of the problem. And so when people start to disintegrate in judgment, then the police are going to get in there somehow at one point in time, especially when there's violent acts. And people who have these kinds of disorders will, at some point, act irrationally, and then when the cops are there, and we've done this many, many times, it's not easy. And so the question of how do you engage someone who is revving up, as they say, with some unusual behaviors that you know can lead to what you described as the opening thing with Aaron Alexis. This man did not all of a sudden appear this way for that particular day. There is a ramp up that is often described in years as opposed to an impulse. And so all I'm asking for by being here is a nice discussion on this, because the answers are not going to be found entirely in our discussion. And it speaks to the fragileness of the human brain. So if we all get into a perspective that the human mind is not only miraculous when it works well, but it can be extremely dangerous when it's not working well to the owner, and then the owner will transform whatever that experience is into the broader society.
Harold, you look like you want to join in. And Laura, one of the questions that, one of the issues that I think that Lee just raised was, is there an anecdote? Is there, if you could talk about that, about, is there an anecdote? We know that these are, the processes, Lee has said, that it's a long developmental process. Mental illness just doesn't appear suddenly. And what can be done?
Well, I think there are a number of things we can do to improve public safety involving offenders with severe mental illness, and particularly individuals who are dual diagnosis with severe mental illness and substance use, which is really where many of the dangerous people, that's really the diagnostic group. People with severe mental illness who are not substance users have much lower rates of violent offending than people with dual diagnoses. I'm very pessimistic that we can specifically identify mass shooters ahead of time, and the idea that whenever someone does something like this, people always look at the trajectory and say there were all these red flags. And the problem is that many of us carry those same red flags. And if you say everyone who's had contact with the mental health system, that's a red flag. Wow, those are hundreds and hundreds of thousands of people. And so the people who have been specifically identified and attacks have been thwarted, it's usually by someone in their immediate family or social network, not by administrative systems that somehow identified them. So I do think there's no antidote to this in the sense that if we had a perfect policy that could detect people ahead of time, we would be able to prevent these. We could certainly do better on gun safety, and we can certainly do better way before this happens. When I think about all the people, so LA County Jail may be the biggest mental health facility, but our Cook County Jail is probably the second biggest facility. And on any given night,
And the third is Rikers Island.
Yeah. We've got and about 2,000 people in Cook County Jail on any given night are people with psychiatric disorders. And now they're not mass killers. These are people who get into fights with people. They urinate in the street. They're the urban rabble that we lock up because we don't know quite what else to do with them. And many of those people, as I'm sure we'll talk about in the conversation, we could do a much better job of both helping and monitoring those people so they're less likely to become either the victims or the perpetrators of violence.
Laura, what are your thoughts?
Yeah, I just want to underscore a point that you raised actually in your very nice question to Sheriff Baca, is the vast majority of people with mental illness are not violent. In fact, the vast majority of mental illness are much more likely to be victims of violent crime than themselves to be enacting violence. There are subsets where we can identify risk. We can identify risk, the individuals where they have many red flags. But then being able to identify the exact moment when something may happen, we're much less able to do. So these are important things. Prevention on a broad level, early identification of issues, addressing comorbidities, the co-occurrence of substance use problems as well as severe and persistent mental illness are really important. But the larger issue is we've criminalized mental illness.
I was going to ask you, how did that happen? How did it become that mental illness became criminalized?
Well,
Laura?
they call it the unholy alliance, right, between the liberal left and the righteous right, which was the movement to deinstitutionalize people living with severe and persistent mental illness. And there were many good reasons why everyone embraced that. But what happened was that there really then became no facilities, no real infrastructure and supports to help people with severe and persistent mental illness, besides the criminal justice system ended up picking up a lot of the pieces. The strongest, the most wonderful program across the country is the VA system, which has done a lot to bring really improved mental health care to people with different kinds of conditions. But basically this complete destruction of an infrastructure and the lack of building a new infrastructure I think has led to really quite tragic consequences.
Lee, when did the problem become dumped on you at the law enforcement level? When did you begin to see the significant problem grow in the jails and prisons?
Well, I think that we've had some episodes in history as to acute increases of people who have mental challenges, but the question is, was this a natural progression from birth that somehow only, I guess, a psychiatrist or a medical doctor could explain? But then in the tradition of affecting one's behavior, we became extraordinarily involved with drugs of various kinds, both over-the-counter prescription drugs and then the illicit drugs. And there are illicit drugs that are out there that people have used and ultimately survived them. But then if you have some natural forms of what I'd call potential mental illness, and then you're going after certain drugs that are not necessarily medically prescribed, then I think what you're starting to do is cause some self-medication processes to trigger into your system where you are not really predicting how this is going to affect you. You're not able to say, this is going to make me better. You really are in an experimental stage. And so that caused for a lot of people to come to jail who are drug dependent for whatever the drug is, legal or illegal. So then the spiking started in the late 60s, in the early 70s, and it hasn't decreased because we go in and out of whatever is the fad of the time. Methamphetamine is an extraordinarily powerful drug. That seems to have subsided. The innocence of cocaine was very popular in the 70s, and it kind of took the place of other popular drugs, and then that's kind of subsided a little right now. So then we've got these new, more exotic drugs that are starting to appear, including gas and propane that people will inhale. And before you know it now, we've got something else. So the whole point of my opening comments about that the mind is miraculously the greatest thing ever created, for those of us who believe in creation, but it is not a tool of steel. It has a lot of components to it that are being learned about by institutions like Stanford and across the nation and across the world. And what we owe to ourselves as human beings is to stop this trending of experimenting with our own brains. That we really don't have the capacity to manage that kind of a pathing. So what I'm trying to do is not necessarily criminalize everything that involves brain tampering, but it does cause the problem to get greater, and then the system, through the absence of proper care while you're even incarcerated, you can end up with no solution at all.
I wonder if you could talk about what is the life like inside the prison for a schizophrenic, a psychotic. If you can talk about the treatment and are your staff able to handle the depth and the breadth of the psychiatric problems that confront them?
Not the way it should be, in a sense of a better way, because you have law enforcement staff and mental health staff, and then there's other aspects of health care that are beyond the mental side of it that are necessary to be provided. And in our case, we have 3,500 people who are under a mental health care watch, and they're also being given medication. My medication budget for the entire year is $21 million. Our thing is to get everyone stabilized, But then when they get out, the continuum of medication is unpredictable.
Which raises a question, I think, of the paradox of prisons is that you may have better treatment if you're seriously ill in prison today than out on the streets. Laura and Harold?
Well, I have been involved in the care of people who are incarcerated who have severe illnesses. And there are many anecdotes I could share, for example, about how the inmates often will do self-destructive acts in order to be identified as being mentally ill so they can have access to service. So suicide attempts, not usually violence toward others, but suicide attempts would be kind of the main thing. And then getting treatment, getting additional supervision, getting access to medications. Basically, it's an improved quality of experience in the prison to have these services available. But then you become further stigmatized, and there are some cultural things within the prison setting that are realities for these individuals as well. I think there are very, very few psychiatrist providers. There's inadequate at most facilities across the country. So there's it's difficult to provide individualized, tailored kind of care. It's difficult to have formularies with sufficient breadth and diversity of medications that could be really tailored. But still, it's better than what many people have when they leave. And certainly the transition as you leave the prison system or the jail system is a big issue. And then identifying someone getting on similar medications or appropriate medications is a huge issue.
Lee, and then Harold?
If I may, one of the difficulties I've been trying to address for years is the privacy of one particular person's medical records vis-a-vis the need for when people transition out of jail. There should be a complete systemic form of passing on medical records, particularly for those who enter the jails, because if you don't alert the community providers and the clinics and the other hospitals that they can check that person's history as it pertains to the medications that they've had in the past, what ends up happening is when they get out of jail, we give them a couple weeks of medication, and then they feel good, and they stop taking the medication, and then they're back into the street circumstances that lead them wandering into a clinic, and no one there knows what their prior history is. So there's a legal challenge here that restricts common sense when it comes to handling indigent mentally ill.
What are the issues that you're thinking of, Harold?
Well, I'll make two comments, one about Medicaid and one about deinstitutionalization. Some of you may have been approached at some point by someone on the street asking you for money. I don't know if that's ever happened to anyone here. And you might be thinking, maybe this person has a mental health or substance abuse problem. And then you think, well, who's going to take care of this person and who's going to pay for that? And it turns out, well, he's not a mom. He doesn't have a federally qualified disability, in all likelihood, so he's not on SSI or SSDI. He may be a vet, but he's not connected to that system in a way that provides care. And you might think, well, if he's poor, at least he can get care because he's poor. And it turns out that before health reform in 41 states in America, if you have an income of $0, if you're a childless adult, you're still not eligible for Medicaid. And a young man who's a childless adult who is dual diagnosis and has some issues, that is the prototypical customer in your shop, and it's the prototypical person who's not eligible for the various social insurance programs and categorical programs that we have that would give people Medicaid. And what's really so transformational about the Affordable Care Act is it says if you are a childless adult but your income is below 138% of the poverty line, which is roughly $15,500, something in that range, that you are now eligible for Medicaid. And for correctional care, in 2012 in Chicago, of the mentally ill people in the Chicago jail, 90% were uninsured. And the sheriff estimates that 90% of them will be insured once the Affordable Care Act is fully operated. And that creates the infrastructure not only for that individual to get care, but also for that ecosystem to get financed. So I'll leave it there because I've been talking a while.
How do you get the seriously mentally ill to go on and get into the program? I mean, I have not seen any targeted programs that go for the seriously mentally ill. So the Affordable Care Act, as you just said, is a great opportunity for care for individuals. But what's the effort to really engage the seriously mentally ill and getting them knowledgeable about the Affordable Care Act and what it can do?
think this is where the blocking and tackling of actually implementing the new law is so critical. Because if we basically hand someone a pamphlet and say, you know, you can go and sign up for this, you can imagine what's going to happen. They slip through our fingers until the next time they're in a crisis. So I think that it's really important that the discharge process from jails and the processes that bring people into institutions, that those are designed to embrace those people in those moments when we actually have them. And I'm sure the sheriff could speak much more knowledgeably than I could. I think it's really important to get this right in the boring details, because otherwise you're absolutely right, we will lose these people if we are passive or if we create barriers. If you say, come back with your shoebox full of forms and we'll see if you're eligible, that's just not going to do it.
Lee, who pays for the care of the mentally ill in the prison? Is that the prison system? Is that Medicaid? Is it here in the state of California? Is it Medi-Cal? What are the fundamentals there in terms of cost?
Yes, thank you. In the county jails in California, there's 58, and I'm on the Board of State and Community Corrections, so in even the prison system, it's paid for by the general fund taxes. There are no reimbursement capabilities currently. That's why the Affordable Care Act that the doctor was mentioning is going to be a huge asset in not only solving things in jail, but it's going to allow us to have assurances that we can solve things in a community. So that in the context of costs, that's one of the big problems, because our mental health department that runs our system is well-staffed, but there's certainly not enough. And when you're dealing with the levels of mental illness, you've got counselors that can detect certain things and nurses and the like, and then you've got to ratchet it up to psychologists, and then you've got to go to psychiatrists in order to get the medication. And so there's this entire flux of people coming in. The 3,500 don't stay the same population for long. The average person in jail under a lower level offense is going to be about 45 days. So you got this 33,500 constantly revolving. By the time you're done with the end of the year, you got 15 to 20,000 people who fit this category or more. The average annual bookings in the jail is about 140,000. So if you take the 3,500, it represents about 1/5 of the population. So you have to understand that this is a moving patient here, or if that's what we're going to call each one, and they're not going to be fixed in like you would a mental health hospital, where you can just have this singular process that doesn't have any interruption.
Laura, you want to jump in?
Yeah, even in a mental health hospital, we're having some of these same challenges. But I had two comments I wanted to make. With the Affordable Care Act, it's wonderful because now we believe there will be some resources for the care of individual patients. But there really is insufficient infrastructure. The system itself hasn't been built adequately, and the different kinds of care that are necessary haven't been built. But there is at least now some resourcing that can help drive that process. But there will be a period of time where we need to build the infrastructure for care so that there's adequate access for all different kinds of illnesses. And the second large, big issue is there isn't an adequate workforce. There are not sufficient psychiatrists, there are not sufficient subspecialty psychiatrists, there are not sufficient psychologists that are interested in working with this particular patient population. So to build a workforce takes years. Primary care physicians and other providers can help kind of bridge the gap, but often these may be less likable, highly stigmatized, more difficult and complicated and complex patients. So we are not really particularly well prepared, but we're very happy to see at least some resourcing to help drive this forward.
So when you look at the reality that if you have people in jails that have families at home and places to go when they get out, that's a whole different potential for success. But when you look at what NAMI and others do to examine the whole population,
NAMI, the National Association for Mentally Ill,
to assess what is the different population potentials, you have homeless people, and what we've done, sadly in America, is not in my backyard. We don't want to be bothered with this. We want to keep this society somewhat marginalized so that they're not visible, and when they are visible, we can just handle it. So there's this whole convergence of contradictions as to how do you really fix the problem, because of what you open this panel with the commentary of the change of law and the the Unholy Alliance, we thought that letting mentally ill people roam free would be a better solution than institutionalizing them. I'm not so sure I would agree with that. What I believe is that human beings in the wealthiest nation in the world should have something suitable in the way of a lifestyle that doesn't necessarily have to be laced with everything that's affluent, but it certainly shouldn't be that you have to figure out every night whether or not you're going to be under a bridge, you're going to be in a doorway, or you're going to be somewhere.
Or in jail.
Or in jail.
Lee, you just raised something that I'd like to ask each of the panels, and Harold, why don't I start with you? Would it be fair to call deinstitutionalization one of the greatest social disasters of the 20th century? And I wondered if I put it in that way, that the money spent, well, first of all, the money spent on deinstitutionalization did not follow the patient outside the institution, and it was supposed to follow them to treatment. Were there any winners with deinstitutionalization?
Well, I actually would give a more positive overall assessment of deinstitutionalization, but a qualified one. I take care of someone who's intellectually disabled. And I think the contrast is actually very interesting between people with severe and persistent mental illness and people with intellectual disabilities. There was a human argument for deinstitutionalization and an economic argument. The human argument was people benefit if they're living on a human scale in their own communities with an opportunity to interact in the community. And I think that is a very valid argument for most people with severe mental illness, for the intellectually disabled and others. And certainly we don't want to have a large population of people living in large institutions that are the antithesis of that. There was an economic argument there were these big expensive institutions. If we just get people out of these institutions, we'll save a ton of money and we can use that money for community services. That economic argument turned out to be wrong. And it was wrong for two reasons. One reason is it turns out the guys that you deinstitutionalize who are sort of playing cards in the institution that you sort of say, why is this guy here if he's just sitting here playing cards? Those are the cheap patients. So if you put that guy out in the community, you can't reduce the staff in the institution, and so you haven't saved much money. And now he needs community-based services, and how are you going to pay for that? The second is, even if you did save money, is there some magical process where you save some money over here and it just kind of migrates over here in a magical way to where it's needed? Turns out, no, that doesn't happen that way. The state mental hospital saved some money, but there's this county community mental health service that still didn't have the money it needed. Now, with the intellectually disabled, what happened was there was a very strong political constituency, and the society as a whole has embraced citizens with intellectual disabilities. And what made the money flow where it needed was there was a really powerful political constituency that said to elected officials, this money is going to go here or we're going to kill you. And it happened. And there's no not in my backyard problem with group homes for people with Down syndrome, for example, in the same way that there is for people with schizophrenia and these other issues. And this is where the stigma and the way that we think about mental illness differently made deinstitutionalization a much more difficult policy to implement successfully. There are many, many people who benefited from deinstitutionalization. They're living in an apartment, getting SSI benefits. They're not institutionalized anymore. But there is this segment of people who needed housing supports, who needed help, and that help didn't come the way it needed to.
Laura, Harold just raised a point that I wanted to follow up with you and ask, have we made significant headway with stigma? And where do you think we have, if indeed you think we've made some progress?
So I think we really clearly have made a great deal of headway with respect to stigma for certain mental illnesses. For example, I do believe that depression is understood to be a condition with a biological kind of predisposition. There might be life experiences that contribute to it. And it's become, I think, much less stigmatized in our society. The fact that there are treatments that are so clearly effective, I think helps. There's wonderful work done by a gentleman named Bruce Link at Columbia that's looked at how people develop stigmatizing attitudes. Excuse me. And what he's shown is that if people perceive conditions to be biologically based, but treatable, that stigma goes down. So going around and scolding people for, holding stigmatizing views does not make a difference. But appreciation of the nature of these different illnesses and conditions does make a big difference. And in general, if there's a biological contributor and there's a way of intervening to bring about benefit, these are the things that become destigmatized over time. So there is a large educational component, awareness component. There's also an imperative for greater science. We need better science in terms of understanding the biological origins, and we also need to know what kind of environmental or other insults, for example, drug exposure to different drugs, that would precipitate the emergence of illness, and then all of the best ways to treat these conditions. All of that work together will also in concert help with stigma.
Harold and Lee, you want to jump in?
Well, let's start categorizing age factors here. My big issue is that the school systems are not able to discern what children are having difficulty with the socialization requirement that we all as human beings have to have. And when you have children who are coming to school and they're just sitting in their seat and the teacher is teaching and they're performing rather well, but they're inside collapsing because of the social mores of the school don't really single them out to be a part of something because they haven't put themselves into a sports thing or a club or whatever. And the bells ring and everybody gets out in the hallways, and then there's the bullying, and then there's the this and the that. And what's going on here is that parents are having to deal with these issues privately, and yet the child is in school. And the school doesn't know anything about what these particular withdrawal things are. And then it keeps on passing its way up into adulthood. Now, you look at the Sandy Hook shootings. I mean, the mother's answer to this was to give her child assault rifles and all kinds of pistols, and he's in his room, and all he's doing is working on video games as to how to shoot and kill. And if this isn't a huge signal that this kid is going not only in the wrong direction, but mom is arming him. And the tragedy is the first person he kills is mother. You know, and yet in the aftermath of a diagnosis of what went on here, the fights they had were enormous, her and him and her controlling personality and on and on and on. Now, I'm not trying to blame anyone necessarily, but I'm trying to describe how there is a difference between where do you get involved and what the county jail is all about. And if you go to probation departments up and down this state, they have children in there so medicated that they can't even get out of bed. And so there's this whole complex need that we need to start breaking out in its pieces. And my biggest worry is not only the adults that are in our jails, but the children who will eventually come to our jails.
If there was one thing that you could change, each of you, in this fractured mental health care system that we've all been talking about for the last half hour, one thing that you would change as the public, if you were a public policy creator, implementer, legislator, what would you change? Lee, why don't we start with you?
Well, you know, it's hard to get the big answer for a complex problem involving so many levels. But my biggest concern is that we don't understand what it means to be homeless. You know, 1/3 are mentally ill. That's because of the institutionalization policy. And then you got people who are indifferent. And so that's why this debate or discussion, rather, more discussion, not debate, but we have to keep on talking about the fragileness of the mind. We have to have a campaign to protect the brain. There are people who don't have the will to protect themselves in terms of what comes into their head. The minute you get scared of spiders, okay, we got to figure out a way so we can help you not be so scared of spiders until you grow higher in your age. But then there are people who have such incredible low feelings inside of them, and they're not expressing them at home, and they're not expressing them anywhere because they don't want to. They don't want to be different. But they are manifesting patterns, and there has to be a healthy discussion out of this. And challenges to survive in school should be a curriculum. There needs to have a better process to teach children, and adults have to be helpful in this, and mature, balanced children have to be helpful in this, so that kids are drawn out, so that they're able to talk in a safe way about why they don't like themselves, why they don't like other people, why they don't like their homes, and what can we balance their lives with Now, there are many children that rather be in school to get away from home. And then there's kids that rather just stay at home. And so all these manifestations lead to somebody who is not going to have a balanced life. And then they start medicating whatever way they choose to. And before you know it, they're lost. And so what I say is that it's harder to grow up today. It's harder to find the right answer. And it's harder to make friends for certain populations. And we just have to do a lot of research to find out which populations are the ones that are not engaged and feel like they're part of the stream of success that America is so famously noted for.
Laura, Lee a couple times has raised the brain, and we've had a decade of the brain of NIH funding. Where are we on research of the brain? What specifically are we doing here? What is the knowledge we've gained? And where do you really see the research going in the future?
No, it's an extraordinary time in clinical neuroscience. And to underscore a couple of your points and then tie it with your question, I mean, what you really emphasized is identifying subpopulations that are at risk, have special kinds of adversity that they're facing, might have some biological predisposition, might be troubled, but then it progresses to become something worse. So this idea of viewing things in a neurodevelopmental way, the stages of life, looking at special subpopulations that are at risk in particular, and how there might be specific interventions necessary for those particular subgroups, and then looking at the projection over the course of a person's life, I think are all really wonderful, wonderful points that you made. So in clinical neuroscience, we're doing everything from the most basic biological research to clinical work, translational work, through community work, and all the way to large populations. I mean, if you look at the public health burden and disease burden of mental illness, it is not just destroying individuals and families, it's really destroying communities, and the burden of disease is bringing down entire nations throughout the world. So these are huge issues that can be studied on a population level. Here at Stanford, we do have amazing work that's going on, kind of looking at the neural circuitry that may become disordered and give rise to the most severe and persistent mental illnesses, to what are the best kinds of talk therapy, and even why do certain talk therapies or psychosocial therapies work for as diverse conditions as eating disorders or severe depression, anxiety, trauma-related conditions. So I would say that having an articulated view of the specific kinds of conditions, having a neurodevelopmental model, I think is correct, identifying certain subpopulations that might have distinct natures. We're working on all of these different issues right now in real time and finding answers, finding effective treatments, finding new ways to reach out to people. So it's an extraordinarily exciting time.
Where do you see it, Harold?
I want to build on two things that have been said. One is using the school setting. And in addition to the biological pathways and understanding the clinical neuroscience, we need interventions that are rigorously evaluated in the real world setting and that are economical enough to reach a large number of kids in a realistic way.
Right.
I'm the co-director of the University of Chicago Crime Lab, and Jens Lidwig is the director, and many others are involved in it. We did a randomized trial in 16 schools in Chicago that Sarah Heller, my colleague, was the lead author on, where we showed that a cognitive behavioral therapy-based once-a-week group intervention with kids that cost about $1,100 per kid in the way it was done, reduced violent offending among participants by about 44% among the kids who participated. And we need interventions, and it's done, and it was done in the real-world environment. It was economical by people. You could scale this thing up. We need more things like that, where we rigorously evaluate them, because there may be 40,000 kids in Chicago who need that kind of help. Some of the violence is committed by kids who are troubled in the sort of stereotypical ways, or people with serious mental illness. A lot of the violence that we see is a couple of 18-year-old guys
Right.
with a stupid beef, and one of them's got a gun, and somebody ends
Right.
up dead. And we got to do something about the gun part, but also helping the average kid deal with the kinds of challenges they're going to face on the tough streets in a place like Chicago or LA, so that they don't have a severe mental illness, but they're testosteronically challenged. They're a 17-year-old boy, and they're in a tough environment.
You raised one of the questions that I think that There have been some questions about the psychiatric field as being resistant to rigorous evaluation. Do you think that that's true? And do you think that that's a significant problem? Laura?
Oh, I thought you were going to ask Carol. I thought you were going to ask Carol.
You were nodding along, so I thought I'd ask you, being the chair of the Department of Psychiatry and being...
I mean, it is interesting. There are barriers. You know, if you're a surgeon, you publish your rate of infection, your outcomes, and it's right out there, and it's tied to you as a surgeon. It's different in psychiatry for many reasons, really related to patient privacy. I mean, we don't talk openly about some of the conversations that we have with our patients, and that's been the tradition. Now that's changing. There's much more in terms of effectiveness and outcomes research that's being implemented across all the mental health professions. And so I think there's a little bit of residual from the past tradition and an honorable concern about the privacy of our individual patients.
Harold?
I'm not, I leave you to you know vastly more than I do about the psychiatry area. I think that we do need to be much more focused on rigorous outcome evaluation, and also, by the way, learning the causal pathways, not just the biological pathways, but also the family, social, economic pathways.
Totally agree.
Yeah.
Yeah.
I mean, I think one of the important things that we started out noting was severe mental illness is not the cause of most of the homicides that are occurring in America at all. The severely mental ill maybe account for 7% of American homicides. So in terms of the violence problem, there's a mental ill offender problem, but in terms of the violence problem, we have to find better ways to reach a very much larger population. And it's partly on psychiatry, but it's also, realistically, most of these people will never see specialized mental health systems. They will see their school, they may visit a social worker, they will not be in places like this campus getting specialty care. And so we have to have strong interventions that are informed by what happens in the specialty care, but that are able to be scaled on a broader basis.
Totally agree. Can I just talk, you know, we've talked about the injustice of how there are not sufficient services and clinical services for this population, but there's also the scientific injustice, the scientific neglect of neuroscience historically, which has really been, you know, a huge issue. It's why we don't have more answers. So I'm not sure it's the field of psychiatry in particular, but it's the fact that overall the public agenda has not been to focus on these questions. And it's obviously terrible that these tragedies are elevating these issues. But one of the things we are seeing is much more attention to the brain, the fragility of the brain, the imperative to do clinical neuroscience studies, different kinds of studies in real world situations. So I'm very hopeful that in addition to the new resources that are going to come to clinical services, there'll be new resources that will help with research to clarify important questions that we're facing.
We seem, though, to lurch from these incidences. Aurora, Colorado, Arizona, Phoenix, Arizona, and Gabby Giffords, Newtown, and now the Navy Yard. And now we're mired in the middle of a political budget crisis. There doesn't seem to be a will in this country to really tackle these deep problems of the fractured mental health system. So Lee, let me start with you. Are you an optimist or are you a pessimist?
Well, I'm an optimist. You know, I think that pessimism is a retreat from creativity and imagination and more work and hard work. I think the issue is learning theory. I think that as we get into the brain science world better and we understand how the mind learns what it learns, that we'll do a better job with the context of the competition that goes on with objective rationality. You know, when you're objective, you're looking for evidence to make your point of view. When you're subjective, you're using an awful lot of the emotional side of your brain. And it's that part of the brain that to me, is dangerous. Most of the major incidents, we had one in San Diego where about 20 years ago, a man who was just following the news on gun control in a law in California got passed to be more restrictive on certain assault weapons. He went berserk because he was going to lose his guns, and he thought he was going to lose his guns. And so he shot and killed in a McDonald's over 13 or 14 people, and ultimately the police killed him. You got to ask yourself, what threatened you to think your guns that you cherish are going to be taken away to the point where you had none? But the emotional reaction to this loss drove him to this place of what I call insanity. And even if insanity lasts for 10 minutes or an hour, and people finally cool down from their emotional threat, then they can step back. But there's jails are full of people who kill other people, not on a mass scale, but just on the moment, because they have this emotional imbalance, and the objectivity of what went on is totally lost. And I'm saying that it's a learning theory problem, because we can actually train our minds to balance ourselves with emotional integrity and objectivity at the same time. And those governances are not easy to find, and they're not even easy to teach. But if you don't talk about it, that the threats of the emotions are going to challenge your objective life, then you're going to find yourself a victim of your own thought process.
Harold, you want to jump in?
So I think there's two aspects I would also mention. One is the criminogenic aspects of the environment. The gun issue, it really is fundamental. It turns out that the U.S. is amazingly average in most crimes that don't involve guns. If you look across industrial democracies, if you want to get mugged, you can go into the London Tube and they'll be happy to mug you. If you want to get your car stolen, Stockholm is pretty good for that. But you won't get killed. Every society has people who are troubled, people with mental illness, people who sell drugs and engage in criminal behavior. That person who's insane for 10 minutes, if he's stabbing people, he's not going to kill 13 or 14 people. And we have to get a better handle on the gun problem. And there are lots of ways to do it that are consistent with our Second Amendment tradition. And I think we've allowed ourselves to get bogged down in where we're not effectively evaluating what can be done, and we're not taking reasonable steps, like a stronger background check system that would be effective. I also think the issue of alcohol needs to be on the table. One of the things that I did a study where we looked at 200 consecutive homicide victims in Chicago who were young men. A third of them had high blood alcohol content in their systems when they were killed. Alcohol is, and we know that many, many offenders are intoxicated at the moment that they commit a violent act. And so we have to deal with that issue better as a society as well.
Lee, are guns at the root of the problem? Laura, you want to say something?
To a degree, yes. I mean, I was in the NRA for 6 years when I was in the Marine Corps, and I understand what the lethality of guns are, but you can't take military weapons and just toss them into the population at large and say this is a common sense thing to do. What I believe is that there's plenty of weapons for hunters, and if you want to collect an assault weapon, then you can certainly have to qualify up at a higher standard to have one as a collector. But what's happened since my days in the NRA is that the NRA was much more progressive in those days, and they didn't want a mass assault weapon infusion in America. But then the leadership changed, and this general named Curtis LeMay, who was a Korean War hero and all that, he got into the leadership role, and he liked the idea that everybody should have as many weapons as there's available. And so what happened is I ended up buying a .45 caliber and an M1 carbine from the NRA for about $20 a piece. And that tells you that the merchandising was being rather loosely governed by that existing time in history, and this is in the early 70s. So what ends up happening is that, how many weapons are enough for your personal use? What becomes your ultimate satisfaction point? And so a lot of people that we get confused with is that what causes a lot of confusion in this thing is that hunters are very good in safety procedures. Rarely will you find a hunter getting bizarre with a weapon and doing something goofy. But because the hunter has that privilege and can handle the privilege, the rest of society wants to follow in and take advantage of what is not sensible policy, and that is that everyone should have a background check. Those that have questionable issues about mental health should not be given the opportunity to own a lethal weapon, because the first victim might be themselves. They can kill yourself with a gun. If you look at the history of deaths with guns, the history is rather profound that people are killing themselves. But that piece, the Center for Disease Control, is prohibited from doing research as to how many people kill themselves with their own gun. And so you have a real difficult way of answering the question, but I'm one that believes that some people are eminently capable of safely keeping all the weapons they have. But then there's a part of society that is not capable of being cautious and train themselves properly. And they therefore, I think, need to be watched a little differently and handled in a different process.
Laura?
I just want to emphasize a point made earlier in the conversation. Impulsivity and intoxication are not mental illness. I'm going to say it again. Impulsivity and intoxication are not mental illness. And my fear, I'm a very optimistic person, but my cynical fear is that the issue of violence in America, which is so profound and has so many determinants, will be just put upon the backs of people with mental illness and dismissed and not engaged in a fundamental way in this country. And there will be many answers related to guns, access to care, early identification of kids with trouble, work in schools, broad efforts. But it's really important that this not be just reduced to a stigmatized, marginalized group and then dismissed as a country.
Totally agree with that, by the way, and not only is that an expression of negative values if we do it, but in fact we will just not address 93% of the homicides in America if we did a perfect job with the severely mentally ill offenders. I'm glad that you mentioned the gun-suicide connection.
Yes.
And I think one of the things that, from a mental health side, I do think we need to have different conversations about gun ownership. And I think that we have to be more willing to have conversations with our patients, if we're clinicians, and also with our friends and family. Say, if there's an issue of mental illness, is there a gun in your home? Maybe this is a good time for you not to have that. Your son is having some problems. Maybe this is a good time for you to store your gun someplace. We know a lot of young people with mental illness. It's developing in late adolescence. People are troubled. There may just be a period of time where it's just not a great idea to have that person in the same household with a pistol. And most suicide attempts that are not done with a gun are unsuccessful, and the person will not die of suicide in most cases. Most suicide attempts with a gun are successful because it's just a much more efficient way to kill yourself. And as we destigmatize issues like depression, I think we have to think about different ways of having a conversation about what it means to own a gun, so that it's normalized to say, there's nothing wrong with you having a gun, but is this really a great time for you to have a gun in your home? Do you really need that gun for home protection? It turns out in Chicago, in 2011, there was one homicide where the motive was burglary, and someone was killed by someone a burglar came into their home and killed them. How many people have a gun in their home for home protection when in fact they have greater issues within their family, or whatever the issue might be, where you say it's a much bigger risk to have the gun than not to have it? We need to have more conversations about that.
The question has been raised about suicides, and I wonder, Laura, if you would touch upon teen suicides. Many communities like Palo Alto, unfortunately, have had cluster suicides among teens. What do we know about the dynamics of that and treatment of that? And are there new ways of looking at this that have really moved us along?
Yeah. So just some basic facts. There are 36,000 suicides each year in this country. So 36,000. And suicide is the third leading cause in the deaths of young people, later adolescents and young adults. So this is a huge, huge issue. I think there's some wonderful work that's being done to look at the three elements that appear to be linked with when a person might actually commit suicide. So there's a lot of work about risk factors in general, but access to means, what's described as thwarted belongingness, like this moment of feeling of loss of place, a shaming experience, being thrown out from one's family, and then pre-existing illness or other condition that would put you at risk. So these are the things that we're kind of exploring and looking at right now. Our department is doing a lot of wonderful work with the local school system with a couple of different innovative models, mostly related to young people helping support other young people. If you are a child or a young person who's thinking about killing themselves, you don't go to an authority figure and talk about it, but you might confide in another classmate and another friend. So empowering and educating and supporting the friend who might hold the secret of another child's suicidality is what we're trying to do, working with teachers, working with young people who are leaders, and we're finding great success with this.
What do
So-
we know about clusters?
Well, they exist. It's not a myth. We have been really trying to study how the new social networking really feeds these suicide clusters. So it's a very serious issue. It definitely exists. Interrupting the chain is really important so that it doesn't become, a whole cascade of suicides in a group of young people. Beyond that, I would just say, it's a real phenomenon.
I want to close this portion of the panel by asking you off one final question, then we'll go to your questions to the audience. What is the bridge that connects each of you together up here? What do we've been talking now for an hour about serious mental illness and the problems we confront and a fractured system and prisons and jails and suicide and guns. What's the connection? What's the bridge here among each of you as individuals and what you represent? Harold, why don't we start with you?
Well, I think each of us is expert at some pieces of the puzzle. There's no polio vaccine for violence, and there's certainly no polio vaccine for the wide array of mental illness and of troubles that bring us here today. But I think that the tools that each of us use, so the scientific base, the intervention research, the running large organizations that have that human responsibility every day, each of us is seeing this problem in its different facets. And the challenge we all have is to bring our respective knowledge to bear in a useful way for the rest of us. Because, are we doing policy research that's actually helpful for the basic science? Are we doing research that actually helps people in the jail actually help someone in a realistic way? I think that's the challenge that we face, is how can we make something realistic and helpful for the other partners that we deal with?
I would completely support what you've said here. But I hear in each of us, I'm the psychiatrist here, I hear a calling, right? I hear a calling to service of the public and fulfilling the public trust, but also a service to vulnerable populations. I hear this in everything you've said, and I hear it in what you've said too. So I would say, in terms of our own personal motivation, what I've heard is a sense of calling, and then underscoring Harold's point about bringing expertise, bringing knowledge to bring about better outcomes for the public as a whole.
For me, sounds almost too simple, but to do public safety, you have to have a profound love for people. It doesn't matter what their status is. And I think that what's difficult is how do people handle their conflicts internally and how do they handle them socially. And I think the difficulty is the socialization process is becoming a little more sanitized, because you look at your children getting on the internet with each other and they don't even know who they're talking to, but they're just totally fixated on this next text message coming in that could be from somebody they'll never ever meet. And that there's a loneliness in this world that is not being addressed. So when you look at the authority figure, like someone like myself, where you have a lot of power to disrupt people's lives for cause, you don't want someone who doesn't care about you as they're hauling you to jail. You don't want somebody that doesn't care about you even if you're being treated in the jails. You have to have a person who has a lot of strength when it comes to balancing challenging circumstances and loves the miracle of life. And if you love your own life, you're going to be well suited to care for others. If you don't love your own life, you're going to not be as capable. So for me, it's just a matter of a calling. I think life is divine, and I think every human being is a miracle.
Thank you. Thank the panel, please. And now we'll take questions from the audience, and we have a microphone. So there's a microphone that this will be handed around.
In California, I'm Jay Jackman, a local psychiatrist. In California, the standard for psychiatric intervention or legal intervention is that you have to be both mentally ill and dangerous. Just being mentally ill is never sufficient to get you treatment. And the question is, given that hurdle, and it does seem like a hurdle, what can we as practitioners do when we see that somebody is both mentally ill, but we can't say that they're dangerous. They haven't committed a dangerous act, they haven't committed a criminal act, but we know they're on the way. What do we do?
Well, what you're describing is episodic threat, which may not be evident in your office, but I think that you're in a prime position to hear someone say, I hate my brother, I want to kill him. I hate my mother, I want to kill her. I hate myself, I want to kill myself. I think that those comments should be taken seriously. And therefore, it requires more than what you're probably capable of providing. And a notification to some outside of the psychiatric world has to be made. And usually it's going to be most likely the cops, most likely law enforcement, because society hasn't figured out institutionally how it wants to handle this sort of thing. Now, the best place would probably be to have another form of psychiatry that specializes in this very thing and just not burden you with having to keep it in your secret office, so to speak. The privacy law protects you, but you should have the ability to let it go to another stage and probably a group of people.
Having a continuum of care so that you're not the only one holding this would, I think, really help with many, many of the issues and the kind of engagement we were talking about earlier, how to reach hard-to-reach populations, how to give additional support. There's only one of you for I don't know how many patients, and carrying that alone is hard. Yeah.
Do police departments know what to do if they get a call from a psychiatrist who says they have a patient who says they want to kill their mother? Do they know how to handle that? Do they know how to process it? Do they know, from your experience with local police offices, do they know how to deal with that? Or do they say thank you very much for the information and hang up the phone?
Well, yes and no to that. Many don't know how to handle this sort of thing because they don't know what the rules allow them to do, but unless that person is acting out as the psychiatrist said. So what we do have is mentally trained people in teams with psychiatrists and psychologists and practitioners. And we, if there's a threat coming from a home, that team would be deployed to go to actually see the circumstance that has been spoken of with the doctor there. And so we do have these people, but you can't send the average cop to this sort of thing because you don't want to take a risk in not having the appropriate pathing occur the right way.
I think we could do a much better job in training police officers and others in social services and others who just come into contact with people how to deal with someone who's not necessarily immediately dangerous but who obviously has a mental health problem. And one of the sad things about the Washington Navy Yard shooting was this person did have contact with a number of people, including police, where he was convinced that people were sort of pursuing him through the microwave oven, and he was clearly delusional, and he was not dangerous, or not dangerous in a way that was recognizable. I think we could do a better job of giving options to people other than arrest, other than going to the use of force, but say, how can you help that person engage a system of care? Now, it's not going to work for a lot of people. And there's always going to be issues of at what point it's beyond persuasion and voluntarism. But I think if we made more attractive systems and we trained people better to recruit people into the mental health system when there's an obvious issue, sometimes we could do a lot better than we do.
I think in the case of Aaron Alexis, the police department was contacted, and they said there's nothing we can do about it. There's another question. Microphone.
Thanks. Fantastic panel. I really appreciate ability to discuss this issue. I wanted to ask you, and it's kind of a comment and a question at the same time. So in my youth, professional youth, I worked at LA County at Harbor UCLA Mental Health Center. And what I find is that the issue of education has not been addressed at all, about the conundrum between the being severely mentally ill and potentially violent because of that severe mental illness, and the understanding of the family and the community of how to deal with that illness. And I hope that maybe there will be a resource allocation for that specific aim to educate, because we see a lot of people who rather be homeless and sit on the streets and be brought to the hospital on a 72-hour hold, only to go back to the street because they were not happy to be at home. At home, people were afraid of them. They did not know how to deal with their violence. They did not know how to understand mental illness. And I think that component is sorely lacking, whereas a society, we're not educated enough about severe mental illness and how could it be correlated with violence.
By the way, one aspect of that, there are some critical time interventions that provide some support for families and training for families at critical moments, say when someone's discharged from a mental health facility or jail, to try to support the family in anticipating some predictable issues so that they can deal more effectively with their loved one and anticipate, sort of negotiate some of the issues that are likely to come up. And there are some interventions that are evidence-based that seem helpful for people who are sort of at the margin of homelessness at critical moments to help those families. So that doesn't address many of the aspects of what you said, but it addresses one dimension, which is the people who end up homeless because they can't sort of negotiate that family connection at a troubled time.
I'm Jeannie. I work in the inpatient psychiatry department here, and in the subject of the violence that has happened, the tragedies that we read about in the newspaper, I believe that the parents, the family, the cousins, relatives have tried to get help for these individuals. They realize they're not well, but the system did not respond because they hadn't done anything, or they didn't somehow qualify for a 5150, danger to self or danger to others. And it's so scary to know that there's people that are so troubled that are building means to do these kinds of things. And if we had some kind of a legal measure, I'm thinking of like an observation time, being hospitalized for maybe 3 to 7 days, where they would be intensely counseled, and maybe we could get at the root of it, get them on proper medication, that maybe this would avoid some of these problems. But right now, all we have is a 5150 and a 5250 and that kind of thing.
Laura, how significant of a problem, which is the question I think is raised, is the lack of pediatric psychiatrists and just the ability, if someone has an aggressive child who they want to get care for, how accessible is care generally in the United States?
You know, it's a huge issue. I mean, there are so few child and adolescent psychiatrists in relation to the level of need. But even worse, there are so few pediatric psychiatry beds in this country. The services themselves have not been built. So it's a very, very real issue. I think what you're pointing out, Jeannie, I really like, is by the time there's an overt threat, it feels like it's too late. By the time you're thirsty, you should have had a cup of water before, right? So this issue of leaving it to that stage is really, really hard for us as clinicians to tolerate. You know, we care about people's rights and their autonomy and their freedoms. We're also concerned about their well-being, and by the time we know that there's an overt threat, it is just so far down the path. It's very, very hard for those of us who work in the clinical area.
Right here, this gentleman here.
Wait.
I'm
Oh,
sorry,
yeah.
someone here, and then we'll go to you, sir.
My son has severe mental illness. He's been hospitalized here a number of times. He was jailed a few years ago after coming at me with a hammer. The judge ordered him to seek treatment and take all medications. He had no medications. I called the parole officer. He didn't know about this. I had to send him the court order. You know what he got? Biofeedback. No medications. A few months ago, he started talking to me again about the hammer. I'm scared. I love my son, but I'm scared for him and for me. I went to the police, and the police said, he's not doing anything right now. We can't do anything. I said, he needs to go to the hospital. If he hurts me, or does something, take him to the hospital. They said, no, we'll take him to jail. And they could not do anything for him, no preventive action. What can we do to change this? This is not just about my son. This is about so many of our loved ones. It's time for a change. And we need to change not only the law, but the careless system, our health careless system that we have that lets these tragedies happen day after day.
Thank you for sharing that story. What can you say about something like that? What can you tell a woman who deals with this, who finds the system so inept and it's not there, and she's tried everything? She calls the police. I mean, you don't want to throw your arms up and say, but that's the reality, I think, of what people are facing in this country, the truth of it. What do we do? How do we solve it?
Yeah. Well, first I want to thank you for your courage in sharing your story. And secondly, I want to say after this, we're going to talk, you and I, seriously. But being able to mobilize adequate supports is the exact issue that we've been talking about. And I think in California, in many areas, we have much more than even exists in many rural and frontier areas in the country, many urban communities throughout the country. So it's really a profound challenge, and I'm so glad we've been shining a spotlight on it today, but it's a very real issue. The rights orientation of the law in protecting the rights of people with mental illness, I honor, and as an ethicist, I think it is extraordinarily important, but it does have the consequence that we are not able to intervene in the way that we as clinicians and as family members feel is important. So it's only through a broad social movement that something like this will change, because it has to do with the social norms, the expectations in our country, which is very rights-oriented. So it's only by bringing this up at more and more venues and trying to get a shared community consensus around these issues that we would be able to have any policy or legal change. Because single cases don't do it. This is the problem. Individual cases don't do it.
This gentleman-
Sorry, I have the mic here.
Okay.
In terms of her question, I'm not going to share my story in front of everybody, but I have a similar situation. But I've recently found out about Laura's Law, and I understand that that has to be enacted by particular counties. And I'm wondering, why isn't it a state law? How does it support families? And how do we get our counties to enact it in order to support, just to support people and to support the public?
Does anyone know about the law?
Yeah, here we have a gentleman who's an expert.
Yes, I handed Dr. Tsai's paper about Laura's Law in Nevada County, California, but it's also operative in 45 other states. It's called assisted outpatient treatment. It was approved by the United States Department of Justice, Office of Justice Programs, as an effective recidivism for both hospitalization and incarceration device on March 12th of 2012. And it can be, and it has been adopted by 2 counties here in California, Nevada County, California, and Yolo County, California. And on October 28th, the Alameda County Board of Supervisors Health Committee will be hearing a Laura's Law recommendation from its public health officer. And the public health officers of the counties need to step up and take the burden that they've transferred off of law enforcement, and instead of endangering law enforcement personnel, step up and start doing things like outpatient commitment. As a lawyer, I understand that it's very controversial. I'm the former chief legal officer of the Special Court Martial Convening Authority at Fort Ord, California, from 1973 to 1975. You talk about no help with transition after you came back from Vietnam. I saw it on an industrial scale. We're having 100,000 more troops being released into the civilian community in the next 12 months, according to the current war plans. The civilian community needs outpatient conservator availability. We don't have that now, and we don't have that because of the understandings that the psychiatrist over here has. You don't have to be dangerous to yourself or others in California to be hospitalized for mental health treatment. You
That's
can
true.
be gravely disabled not able to provide your own food, shelter, or clothing. And so, if you have a mother who wants to take care of her child, she's forced to make the decision to make him homeless in order for him to get help. And that's disempowering families, and we need to re-empower families and stop empowering public health officials who don't perform their duties.
Thank you. You made a great point. Sir, you've been waiting here.
I wanted to ask what the panel thinks about the fact that the violent video games, violent television series, and violence in movies is so popular. People really want that type of entertainment, and I imagine that most people can put it in its right place where it's just entertainment and not reality, but many others would then think of that as being a normal way to deal with their problems.
So let me put that in a headline. Is Hollywood really responsible in many respects for the games they create, the films they create, the violence they create in films and games? How responsible are they for the violence in America?
I could comment on that. I mean, I have 2 teenage daughters, and the idea that their boyfriends or potential boyfriends are listening to this stuff is not my favorite thought. But you know, the dreck in popular culture is everywhere. And you go to London, you go to Paris, you go anywhere around you go to Japan, high levels of pornography and crud in popular culture, and you don't see a lot of dead bodies. And I'm a lot more concerned about what's happening in kids' lives than I am about what's coming across through their earbuds. And I think that if a kid is, for instance, if a kid is getting a lot of misogynist messaging from their hip-hop music, which is something that a lot of people are concerned about, if the men in their life are modeling respectful ways to treat the women in their lives, that kid's going to be okay. And his father or other adults can talk to him about what's in that music and help show him the way to be a successful adult man. If he's not seeing that in the life around him, that's when the toxic popular culture is reinforcing the void. But the problem is the void, not the popular culture. All over Palo Alto, kids are listening to the same crud that kids are in places where kids are getting shot a lot. But because they're getting other kinds of supports, the kids are going to be okay for the most part.
Great point. Models matter. Who has the mic? Right here.
Hi. A lot of people have brought up very good points, and I think one of the things that is important to know is that it's not just danger to self and danger to others. There's also this third criteria, gravely disabled. One of the things that you said earlier about the mental health system being fragmented, I think is one of the key points, is that we do have effective treatments. We do have well-meaning laws, some of which have gone awry, but they're being implemented differently in different states and very much so in different counties. So for example, as this gentleman was pointed out, Laura's Law is in 2 counties in California. The 5270 type of hold is in LA County and one other county, but not in any of the Bay Area counties, and so on and so forth. There's other laws I could cite. The Meredith Law is completely interpreted differently, county to county, and so forth. So one thing for the mom to know is that there are things that you can say to police about, my son is, this third criteria, gravely disabled, is unable to provide for food, clothing, or shelter. So if you say he lives at home, I provide for his food, clothing, and shelter, he cannot be home in this current condition, that's something. The problem is not all the police know about it, and sometimes I've coached patients' families to kick it up to the next level and to try to say just the right thing, but not everybody knows about it. The problem then, once they do come to the hospital, and there's quite a number of people in the audience who also work with me at the hospital and that we're dealing on this with a daily basis, is that once we have helped them, they are doing somewhat better. They go back out into a system where either insurance isn't available, different counties are fighting for not taking this patient because it costs them money. And so county by county, they are forced into situations of being homeless again, going back to the situation that they came from. ready access to drugs of abuse and weapons. And then you said something interesting about the privacy laws, because HIPAA, which was meant to help people in general not have their insurance company cancel their insurance, we now, as physicians, are not able to talk to other people who know, so family or other physicians who know this patient's history. So we have to go blind. If the patient says, you cannot talk to my mom, you cannot talk to my doctor, we're not allowed to do that. So there's a whole bunch of things that make it hard to do the care that we would like to do and that patients would benefit from. And I think it's a matter of defragmenting, or whatever the word for it, unfragmenting, coming together and working together.
And Lee, you said before the panel you were talking, and you were saying how a recession further complicates this. Could you expand on that a little, on the point that was raised, that we have a fractured system to begin with, and then you put on top of that a recession, and what's the impact?
Well, a lot of the solutions for healthcare and education are public dollars. And when recessions hit, those dollars go down and then programs get cut. And so we're in a quandary here, because you gain a lot and then you lose a lot. And then to bring it back is harder than what one can imagine, because then you have to reenact a series of laws to bring it back, and then you have to compete with other phenomenon in what government spending is about, whether it's jails, public safety, roads, all the things that are the maintenance forms of government. All that fits into the equation, and it's not easy, and yet there are hope points. This is not impossible, and my point of view is that we need to gather all the laws that pertain to what we're talking about. And we need to come to a consensus of how can these laws be modernized. They were enacted in periods of time, and the problem keeps on getting bigger. And we need to do a little more effective ways of doing things, like the lady that stood up. A lot of the ignorance is what we're talking about, that most of our society does not have to have a challenging experience with mental illness. So the question then is, should they be educated enough so that they can understand it when it starts to appear? And that's where the problem is. It's a lot about education. The best policies in the nation are predicated on a lot of thoughtful development, including our Constitution. People hammered out various points of view to the place where we were able to find a way to create a Bill of Rights, and then you have the overall arching purpose of our nation. But the sustaining of society is why we have countries. When the history of development of the world's countries was based on protecting the various tribes that were within the regions of the world. And so these nations didn't emerge with full governance perspective. It was just which tribe could do the best to cordon off a large piece of land. So now we're talking about the land of society that is filled up with a governance process that is spread to 50 states. Much of it is not standardized across the states. And then you have a national system that dips in and out. Mm-hmm. And so what it looks like is a web that has got a lot of entanglements in it, and we need to disentangle this web of law and get right down to the empowerment basics that the lady asked be done for her child.
You wanted to jump in, Harold, and then we're going to do a final question right
and
there.
Just on the recession point, one of the real problems with having mental health siloed in its own category and funded in a separate funding stream by states and localities and counties is when you have a recession, state budgets, all the public budgets are under enormous pressure. You don't want to cut Medicaid services, because if you cut Medicaid services, you are losing a lot of money from the federal government that matches it. So what's happened is a lot of the most painful cuts in the mental health system are to the outpatient non-Medicaid services, which often are serving precisely the most vulnerable people. And one of the things that's one of the important things about health reform is to say we're going to bring substance use and mental health services within the arena of the rest of medical care and fund it within Medicaid with essential health benefits that say you have to cover appropriately within people's insurance and within Medicare and Medicaid these services. And I think one of the things we've seen since 2007 is states all over the country, and certainly in California, have really cut a lot of the non-Medicaid things, and it's been very punishing for the safety net.
And we also now have half of the governors in the United States, and I don't want to be partisan, but I will be, Republicans who have not taken for granted the Medicaid dollars that are coming for the federal government with the Affordable Care Act, which is further complicating the lives for the mentally ill and the vulnerable in society.
And some of those people, if you say, let's talk about gun violence, they'll say, well, it's not guns, it's the mental health problem. And then there's the same people who are turning down the Medicaid expansion.
Right.
Then my head starts to just
explode. Go ahead.
Yes, I'm Jim Bauer, and I want to thank Dr. Roberts and the panel here today. But my question is, and I've raised money and been a lobbyist for a corporation in my career, how do we engage, how do we educate, to use your terms, how do we educate our elected officials at the local and especially the state and federal of these issues? Because you raised a lot of really good points today. Some of them we were aware of, some of them we weren't. But how, somebody who's missing here today are our elected leaders. How do we educate them so that we can effectively advocate for improved services at all levels?
So Lee, let's start with you. How do you spend your time electing legislators?
Well, I've always claimed that if a person is not secure with their mental capacity, they're not a safe person. Okay, they can be found in a system and webbed system that will further exacerbate their quality of life. So public safety is the one tool that everyone pays attention to. It's kind of like the defense forces of America. And it's easy to get their attention. I can assure you that everyone that's elected in California returns my phone calls. The nature of the broadening of responsibilities should be that public safety does involve health care. It does involve the security of the individual in their capacity to be independent when they're an adult and function in a way that is productive to that particular adult, which will then be productive to those around that adult. So what we should do is examine the cause and effect of criminogenics relative to the criminal justice system and say now the criminal justice system is now a part of the healthcare system, which now will allow for everybody to share the strategy of costs. And so I would rather see a lot of people be given the education they need. I'm the chair of Fight Crime, Invest in Kids. It's a national nonprofit, and we've done massive studies as to dropouts in school and what that means to the future of prison overcrowdedness. And so it's all connected. The personal safety of one person should be heightened to the debate so that the policymakers that are elected are given a recipe and redefining what human safety really is. And the absence of crime alone does not mean people are safe. And all the homeless people who are out there, and there's in LA County 80,000, that's my biggest worry right there in the sense of how safe are they. So I think we need to get out of the weeds of where the history of law has led us to and open up the sky on taking the best of those laws and then incorporating them into a broader public safety strategy. That's my only idea.
I'll just comment briefly. And this is a sad thing, but people often do not care about vulnerable populations. They don't care about the mentally ill. So we have to be extraordinarily intelligent about the issues we link it to. So if you link it to the problem of overcrowding and cost in a criminal justice system, if you link it to the incredible economic impact that an untreated mental illness has for the economy of the United States, if you can link it, the average age of onset for mental illness is in 14-year-olds. When elected officials have their own kids, their own teenagers, making it real and linking it to something that they care about, their own children, their own family, the economic viability of the country and businesses, huge social issues. So my own view is that just beating the drum around mental illness is probably not going to be sufficient, but we know the connections with these things that are powerful and important to them, and I think those are the things we need to be talking about.
I think I'm optimistic about this. You know, everyone in America is connected to someone
That's right.
who's been touched by this issue. And, you know, health reform has been such a bitter, divisive debate, but the mental health aspects of it, less so. And Keith has done a lot of work in this area and can express it much more than I can. There are a lot of conservatives, there are a lot of Republicans who are very concerned about this issue. And
they're all concerned about Alzheimer's for sure.
And fair point. I don't think this is an issue where we divide ideologically in the same way we might on other things. And I think we have to build on that reservoir of human concern. And I see a lot of evidence that across the spectrum that people are really trying to find better ways to do things. And I do think that the more evidence we have of stuff that's effective, I think people are sad about this problem. What they are not is convinced, here's some operational things we can do that are really going to work and that are economical and feasible. And so you got to show people, here's some stuff that we have that's going to be effective. And I think that there's a real reservoir out there of people looking for answers, and the system will respond if we can show things that work. I think that the elected officials are motivated to respond.
On this World Health Day, Mental Health Day, let's all be optimistic that we can do something individually and together. And thank you for joining us, and thank the panel.